Okay. So I wanted to characterize here in considerably more than 15 minutes what I consider some of the most promising responsive strategies for addressing chronic disease disparities, particularly in the area of creating models for this. And, you know, much of this talk is reflective of the sort of common underlying set of health disparities that unite diverse areas of the world. The presence of profound heterogeneity, the fact that certain subgroups are often beset by these terribly troublesome, terribly burdensome syndemics of different conditions, and the very critical need in the health disparities area to recognize these differences between groups, to not merely glom everyone into the same statistics and the same subpopulations, but to recognize transfer effects, to recognize that our policies may favor one group at the expense of another, and to recognize that there may be interventions needed that recognize the occurrence of these disparities, recognize particular vulnerable groups that require intervention. There are life course impacts. We know that there are lifelong impacts of early life insults since the work of Barker in the middle of the last century, and we recognize that understanding longitudinal trajectories and that life course perspective can be key for identifying possible outcomes of adverse life experiences early on and in shaping individuals' livelihoods for the better. We're dealing with a situation where networks often provide a central causal structure of significance, whether it's family structure within the context of early life exposures and influences, the occurrence of social capital. Networks form this conduit for knowledge, attitudes, beliefs, risk behaviors, norms. They shape us, and we shape them. They often clue us in to the presence of particularly keen people, say as linkers between different communities, or as individuals who are likely to be involved in early adoption of certain innovations. These networks may be at the individual level or between service centers, between different organizations. Spatial location is also well understood to have profound effects in terms of health disparities, whether it's aspects of racial or income segregation, the fact that there's this geographic rooting of particular drivers and disparities that may be reflective of differences in opportunity structures that vary dramatically across a landscape. There's profound disparities in terms of health behaviors. There's large differences in terms of the pattern, say, of smoking across different ethnic groups, and the burdens of smoking across those ethnic groups. We know that individuals, in terms of their impact of health disparities, much of their behavior is situated in space. And it's situated in a network context. So their awareness, for example, of options in terms of neighborhoods to which to move, or of schools in which to participate, in which to enroll. These things are often shaped critically by their social capital and by their particular geographic context. We're also aware of, in many cases, we have a very troublesome interaction of comorbidities and syndemics, such that the same communities, often lower income communities, are simultaneously afflicted with very high burdens, not just in one chronic disease, but in multiple chronic disease. And not merely that, also in the area of communicable disease, often the area of dysfunction at a social level in the form of factors such as domestic violence, in the form of addictions. So we'll often have disproportionately heavy interactions between conditions where those conditions can often, it's very hard to separate them. Think about the interactions of substance abuse, violence, and addiction in the area of spread of HIV, for example. We're often very concerned with multiple relevant scales, disparities within between individuals, households, neighborhoods, schools, and whole regions, where we'll often see different dynamics at these levels. We're interested in understanding the dynamics of relationships, such as parent-child mental health issues, relationships of individuals with their caregivers that might be absolutely central to quality of life, length of life, and also to cost, in as much as it can forestall institutionalization. And it can be an important enabler or barrier to effective delivery of care. And finally, we're concerned about health services accessibility across different regions. Now, understanding these considerations I see as quite key to reliably understanding at a broader level the dynamics associated with the baseline situation within a population, but more importantly, understanding the effects of interventions, often interventions which have never been before examined, and targeting interventions effectively and designing a system differently to achieve health goals. Now, there's some important needs that are corollary to this. The need to capture heterogeneity, life course effects, spatial location, all the factors I've just mentioned. We seek tools in terms of prevention science that will help us grapple with this complexity, these undeniable types of considerations I've just mentioned that are central to the disparities context. But we also seek tools that help us reason across these different levels, that help us reason at an abstract level, at an individual level, that help us anticipate and incentivize behavioral responses, help us characterize health behavioral pathways in a more reliable way, and that help us govern our actions, our policies in a way that's adaptive and responsive to new information as it comes in, the latest evidence. So in response to many of these needs, we've embraced a variety of approaches, many of which are listed here, that try to address these very real needs in the health disparities area, and particularly push the envelope methodologically in order to open up new avenues for effective addressing of health policy prioritization within the area of health disparities. So I'm going to be talking about ways in which some of these specific needs we've been discussed are reflected in the sorts of approaches that we take. And the first one I want to highlight is this need to capture heterogeneity, life course effects, spatial location and networks, situated behavioral influence, comorbidities and syndemics, and multi-scale phenomena, as well as flexibility in the level of detail. And for that, we turn for much of our work to agent-based models. Agent-based models, as I've emphasized in the course of this masterclass, have this ability to represent situated perception on the part of agents. They might, for example, gather information just from other individuals who are immediately adjacent to them in their network or nearby in space. We can capture longitudinal progression, as we did with some of those statistics in the course of the master class, capturing information on episodes of obesity or the first time someone is obese, capturing things such as birth weight or the status of a mother at time of birth. We can capture aspects of a person's history. It can be very important for identifying opportunities for effective intervention, for example. We can represent spatial, network, and multi-level context within an agent-based model. We haven't explored this in the course of this master course, but any logic in particular can very readily create these nested levels of context, where individuals can be embedded not just in Maine, in populations, but also in a separate city agent or a neighborhood agent that would live within a city. We can represent heterogeneity. We saw on the very first day, adding a new aspect of heterogeneity, perhaps socioeconomic status, to an existing agent is a fairly lightweight operation in terms of the impact on the model structure. And this, by extension, supports the ability to represent multiple comorbidities, for example. And all of these can provide support for highly targeted policy planning. As we'll see, a key part we see in this is representing relationship dynamics of relationships, say between this triad of informal caregiver, formal caregiver, and individual with a condition that Jeff has been so instrumental in identifying. So, we seek here to build models that get closer to the heart of the matter. There's been quite a lot of work within the broad health modeling area where we're dealing with models that don't really engage with a textured representation of the health behaviors associated with the situation. They're dealing perhaps with aggregate statistical characterization, but they don't really represent at a detailed level the causal pathways. And I particularly highlight aggregate models here. And the fact that within aggregate models, often there's an omission of behavioral pathways, or behavioral pathways are depicted for nearly meaningless typical agents. So we represent a feedback, for example, for a typical agent in the population in a way that doesn't have a clear meaning associated with it, and where many of those from the health sciences side would feel really uncomfortable formulating policies on the basis of a typical agent in the context of such profound heterogeneity. Aggregate models are often forced of necessity to omit key aspects of situated context that shape behavior, such as networks particularly, but also spatial context. And they have difficulties capturing path dependence. The fact that a given person early in their life was exposed to a certain traumatic experience, or was subject to an early life insult, perhaps gestational diabetes in utero. They have difficulties capturing heterogeneity in a scalable fashion, and they'll often omit differences in the preferences of particular agents. So we've made use of agent-based modeling in a wide variety of contexts, and we believe it's quite central to our research agenda related to health disparities. It's a tool that has a privileged place for this area amongst the system science tools. But a second thing I want to highlight is the need for flexibility in the level of detail represented. And for this, we've turned to not merely one system science technique, but multiple such techniques, most notably multiscale and hybrid modeling. It's my firm conviction over the quarter century I've worked with dynamic models, very, very heavily multiple types of such models, that multiple types of system science methodologies, system dynamics, agent-based modeling, social network analysis, discrete event modeling, they're actually highly complementary. Yes, they differ in terms of how they depict the situation, but more fundamentally, they differ in terms of the questions they bring to the table. And it's my firm conviction and observation that great synergies can be secured by using combinations of these methods. And we found the use of multi-framework method for being highly, highly effective in terms of pushing the scope of what we can accomplish with the model. And of course, several types of hybrid modeling we've used in the course of this week have included those here. This case of a budding model we examined this morning, where much of the population, often the large majority of the population, is represented in an aggregate fashion, as befits the fact that it's outside of our focal point of interest. But then those then members of the population, once they develop to a certain point in the risk continuum, they are individuated as agents. In other cases, we've seen the ability to drive a model using results from an agent population with higher level structure. We've seen system dynamics models within agents to capture continuous dynamics, often very theory-based dynamics. And we've seen, and we haven't seen, but we could easily imagine cases where we have agents, each of whom represents a patch in space, and that patch's dynamics are characterized using system dynamics methods, a technique we've used to good effect within the zoonotic area, where each such patch represents an area of land. So each agent represents some region of land, and the dynamics within that region in terms of mosquito populations and bird populations and the dynamics of disease reservoirs are captured with system dynamics models. Another very, very powerful technique is the combination of agent-based models with discrete event models. In this context, very, very well supported by the platform we've been using here, AnyLogic, we have a population depicted as agents, and individuals in the population can present for care as a result of changes in their health state. In this context, individuals flow into a clinic context or some other institutional context where they go through a defined workflow and where their progression and their timing within this flow, within this process, care process, is dictated by availability of resources. Availability as diverse as doctors and nurses, diagnostic equipment, procedure rooms, and other components such as beds. So here we have an agent-based model used to represent individuals in a persistent way in the population throughout the life of that individual, but their encounters with the care system are captured in a very convenient way using discrete event modeling, which has exquisite level of ease of describing the flow through resource-constrained processes and capturing queuing as a result. We've made use of these hybrid techniques in a wide variety of areas, and I'd highlight specifically the capacity in AnyLogic to shift that boundary. Exceptionally important. What it means is, far from having to go into a modeling project ahead of time, knowing what part of it you'll pursue with system dynamics, what part with agent-based, what part with discrete event, you can allow that boundary to evolve as your learning evolves, as your sense of the sensitivity of pieces of the model as it becomes fleshed out. You may decide to zoom in on certain pieces, aggregate up on other pieces, and you evolve that boundary with your learning. Another need is the need to understand and nudge microbehaviors on the part of individuals. And here we've made a central point of linking in with what's increasingly known as big data. A key reflection here is that while we often seek to inform, particularly interventions aimed at health, specifically at the health disparities area, with understanding related to location, factors such as physical activity, spatial proximity of individuals, aspects of their social context, communicational related factors, including communicational disparities in decision-making rules and heuristics. This sort of information can be very difficult to reliably secure. In absence of understanding of these sorts of behaviors related to these factors, the potential to qualitatively evaluate certain policy trade-offs can be very limited. So our work here has taken strong advantage of the fact that smartphones have achieved a remarkable level of penetration in society. And this penetration is reflective of the fact that they pack an incredible amount of functionality in a single package. While the level of functionality they offer is widely recognized, what's less widely recognized is that it's made possible by large batteries of sensors that are present within the phones. So a lot of our day-to-day needs that are addressed with these phones are in fact made possible using sensors aboard them. A second thing we've taken advantage of is that we are living now in the midst of an enveloping wireless cacophony. We are surrounded at all times by all sorts of signals. GPS signals, signals associated with our cell phone network, Wi-Fi, signals associated with Bluetooth for shorter range communication, RFIDs. These are routinely used for communication, for operational needs, for connection and communication. These signals, it turns out, can be repurposed, like the sensors, at virtually no cost to provide other sorts of information. Location, indoors and outdoors, proximity of different individuals, and disambiguation of context. So we've taken advantage of this over the past 6 years or so with a second-generation sensing system. We first started in this area 2009, 2010 with the flu pandemic. Our Generation 2 sensing platform is based around Google Android smartphones. In earlier years, we needed to roll a custom version of Android, but in recent years, this has been a standard Android 4 app, albeit a very intensive one in terms of working with the phone. It runs atop richly functional smartphones, phones that are fully functional in other domains, so there's a lot of internal incentive for people to carry these devices. And we collect data episodically from the phone to preserve battery life. So we go through these bursts of data collection, which might be 30 seconds across for some of our recent studies, 5 minutes across, 10 minutes, 10 minutes apart, etc. We have diverse sensor modalities supported, and there's an opportunistic data backhaul that brings data from the smartphone to our servers where it can be analyzed. Now, the benefits of this fit into the benefits more generally of big data as they've been articulated by many other speakers. These include the so-called 4Vs, the variety of the data that's cross-linked. Think location, physical activity, social context, aspects of people's answers to various batteries of questions. The veracity of the data, we're picking up things in a way that's, such as physical activity, in a way that's likely to be much more reliably than people self-report, something we've known since the NHANES 3 study. Velocity of the data is coming in very quickly. We get data in every few minutes, sometimes once a minute. And also the volume. These days, roughly 50 megabytes to 100 megabytes per person per day of data collected by these devices. We have a secure opportunistic backhaul that can use Wi-Fi or cellular connection. In some cases, we've used manual uploads after collecting phones, which brings data back. So some key health areas addressed, not surprisingly, map onto those which I mentioned as being difficult to address previously: location, physical activity, spatial proximity, social context. So we can track, for example, contacts over time. I had mentioned to this group the fact that network data is becoming increasingly easy to collect. And we have certainly many hundreds of gigabytes of data, probably specifically on networks. In any case, it's extremely large volumes, and we can capture not only at one time, but we can capture change in networks. In this case, showing change from week to week, but we can do this at a multi-minute level of resolution. For example, we have papers published where we've used network data collected about every minute during the flu pandemic and linked it up with simulation modeling to do what-if scenarios related to the spread of infection. We can capture things that are very difficult to capture through self-report additionally, or very burdensome, such as the duration of contacts between people within a population. Think between a mother and children, for example, in as much as it affects norms related to eating. Think about capturing the fraction of meals that they're spending at home, or the amount of time they spend together physically active. These are the sorts of things we can capture. Now, much of the benefit of this data comes from exploiting an analog to what's known as Metcalfe's law. Metcalfe's law was named after Bob Metcalfe, the inventor of Ethernet, who argued that the value of a network, of a computer network, goes up, well, computer network as an example, goes up not proportional to the number of nodes in that network, but to the square of the number of nodes, because of the capacity. Each new person added to the network benefits from being able to communicate with any of the people who are there already. And much of the benefit from this sort of data comes from the ability to cross-link it. So we can map out activity level over space, for example, over a city, where social interactions take place throughout the day. And we can use that sort of insight to ground our models. This sort of data opens up profound opportunities for the sort of dynamic models we've been talking about in the course of this week. Big data at a very high level grounds the models. Grounds the models with empirical data of the sort that would have been unimaginable even a decade or two ago. Rich grounding in observations provides databases for model parameterization and calibration, and it can help stimulate dynamic hypotheses. Dynamic models, by contrast, help us make sense of this data, helps us link it into decision outcomes. What are the implications of this data to possible intervention choices, for example? It can capture regularities that underlie sensor data and can actually help us shape how frequently we need to measure the data. It can also help us understand the implications of the data we do measure for more distal outcomes. Think about the implications of network structures we measure during the flu pandemic for likely high burden areas in terms of spread of infections, so that we can do testing in certain regions of the population that might serve as good sentinel regions. Now, it turns out that dynamic models in this sort of data can be combined in many sorts of ways. We can parameterize models to certain types of the data. Think about network patterns measured from the devices we could simply put into the models, impose upon the models. I've provided example models on the drive for this masterclass, where it reads in from a database connections and imposes them on the individuals represented in the model. And when we've pursued that, we've typically drawn data from these devices, this proximity data, data on people's contact patterns. And you can undertake similar things with mobility patterns. For example, we can also boil down the data for other types of higher level parameters. For example, we have work going on automatically classifying smoking from data collected with these phones. Something you might be very skeptical about, but which is surprisingly accessible given the triangulation from multiple types of senses. You're outside, you're standing, you're pacing. You go in and come back via the same route without going anywhere outside. You're engaged in small levels of activity. You're near other smokers. And from that, we can do things like try to deduce the frequency of switching from a non-smoking state to a smoking state. So we can derive parameters regarding people's likelihood of going from one state to another, for example. Those hazards as we captured in those state charts. Another thing we've done is calibrating models to data, trying to get models to match the data as measured through the phones as an emergent property of the model. We've done inferencing using the data, and in some cases, we've trained models using data, trained hidden Markov models, machine learning models, using data from simulation models. So using data as ground truth to evaluate the reliability of inference schemes, for example. We've used IFE in a wide variety of studies. Here are some of the studies. Many of them have been funded within just this past year and are going on right now. These include studies related to gestational diabetes, studies related to the impact of pro and anti-tobacco messaging, studies related to the impacts of interventions related to flu spread in a RCT from a US CDC funded study, impacts of the food environment, and particularly aspects related to foodborne illness. and some recently funded studies related to depression and mental health and suicide prevention. One thing I didn't mention about the phones, and somehow I omitted the slides, but it's very important. In addition to all of the sensors aboard these phones form a formidable additional platform for two sorts of data collection. Number one, surveys that are on device that can be either triggered by context or at random times during the day in a typical ecological momentary assessment fashion. Our phone can have surveys that are triggered based on, for example, your entry into a park, your departure from a park, based on your social context, detecting a certain number of people around you, which might indicate a crowded environment, using aspects of Bluetooth. So we can trigger these surveys, and those form a key and absolutely indispensable level of additional data collection. The sensor data by itself is valuable, but it's much, much more valuable if you have survey data that can ask about people's affects, about their perceptions, about their attitudes, beliefs, about the intentions behind the information being gathered. So we have this platform that's a sophisticated survey platform, but also a crowdsourcing platform. So people can press buttons to indicate, for example, when I'm starting to smoke, or when I encounter another smoker, or when I'm taking my insulin, or when I'm measuring my blood sugars. And this can be indicated with a button press. So you think about something like reporting occurrences of tobacco messaging that I encounter as exposures, and then us being able to know where that was and tracing other participants and their exposure to the same exposure, and looking at that in terms of outcomes such as smoking behavior or smoking-related, tobacco-related cognitions that we might elicit through surveys. A further area where we've been working is this area of nudging microbehaviors and incentivizing certain behavioral responses. And this has been work that I've been privileged to pursue with the leadership and decade-long foresight of Dr. Jeff McDonald. It's work that's leveraged discrete choice theory or random utility theory together with agent-based modeling. So the idea here is we've used discrete choice theory through Jeff's long-term vision to characterize a grounded, empirically grounded understanding of how people behave under different choice contexts, and how individuals, in light of their particular preferences, tend to behave. These are tools that have been applied extensively in an unseemly fashion in the marketing area to try to sell product, try to push product on people who often have limited need for it. But in this domain, in the health domain, we can use such techniques, understand something about how people's decision-making changes given their choice environment and given incentives in place. By so doing, it can provide us insights into how interventions that might change the incentive system, think raising tobacco taxes, eliminating the ability to use coupons for tobacco, changing the pricing of sugar-sweetened beverages, how that might impact people's behavior in a situated context. That's the beauty of it. We can have agents in a certain specific context and understand the impact of interventions on those agents' behaviors. So discrete choice theory here gives us a way of assessing a grounded understanding of how people choose, statistical tools for estimating individual preferences, and ways of eliciting those preferences through particular survey instruments. Agent-based models here provide us a way of capturing the changing choice set environment as an individual goes from one environment to the other. The availability of fast food might change. The availability of, for example, options for physical activity might change. They might undergo experiences that change their preferences over time, and we can capture that in an ABM in a way that traditional discrete choice theory would not. We could capture behavior of other people around them and real-world responses of that agent to change. I won't go into how this is decided, but there's a broad theory that involves many different types of models. The simplest one is shown here, Logit model, that involves how a person will change and the likelihood of selecting a particular option in light of the choice sets available and the levels of preferences is captured through and the influence of different preferences is captured through the betas here. So we've used this, we've been privileged to use this here in the optometry area in some work that was published in the Winter Sim conference of this past year. There's some work going on we're really excited to be part of at the NIH that my student Kurt Kruger is pursuing with tobacco product choice. And we're hoping, this is actually, I thought I removed this, but it's the direction we're hoping to go with our Ministry of Health project to understand decision-making as regards to patient flow, how people decide different options in their flow through the healthcare system, say a personal care home versus home care, in light of their individual preferences, their situation, the prospects of waiting, cost, etc. So random utility theory provides us a really exquisite way of capturing preferences, capturing the impact of preferences on decision-making in a way that can be neatly incorporated into agent-based models. Another component is this idea of having adaptive models that take into account unfolding uncertainty and incoming data. And here we've been working to link dynamic simulation model with computational statistical tools, particular predictor-corrector models, such as the particle filter or Kalman filter, with a particular emphasis on the particle filter. So the idea here is that these are techniques that balance, take a model and bring it together with incoming data in a live fashion. So far from building your model and then just using it for insight subsequently, you actually keep the model current and periodically reground it on a very ongoing basis with incoming data. What does the data bring to the table? Well, it brings the latest evidence, right? Here we can tie down the model in a way that wouldn't be possible if it were done open loop, in other words, without data to shed light on it. We can maintain the model freshness by regrounding the latest evidence. It provides the model with a better understanding of the current situation and helps avoid overconfidence in model output by tempering model predictions with what the data suggests. Now, the reflection here, folks, is that even the most rich will eventually diverge from real-world observations. There's too many stochastics out there. There's too many factors omitted from the model. Even if our model estimates were all bang on, they may become outdated. And just as you would never want to try to get home with your eyes closed, even though you have a very, very good mental model of how to get home from here, you would always want to do it with your eyes wide open to take into account these things that are not part of your mental model and the limitations of that model. We seek a similar thing with our model. We want to work with our models with their eyes open. And we do that by bringing them together with data. Now, what does it bring to the data? I mean, after all, if we have data coming in empirically, why do we need models? Well, for a lot of reasons. One of them is to be able to look forward and to ask about counterfactuals. Ask about these counterfactual situations that we haven't yet observed. So the idea here is to take a model that may be horribly off base, and I've shown this in an extreme case, where the model itself and its predictions shown in blue are way, way off base. But the model actually learns some from the incoming data. It's regrounded with a new piece of data comes in, the model says, oops. Just imagine you walking for about 2 minutes with your eyes closed towards the bus stop, and then you open them after, oh man, lucky I didn't take 2 more steps that way. You reground yourself, and you correct yourself. And then 2 minutes later, you open your eyes again, and you reground yourself. And by doing this, the model can be used to cast forward. It can be used to ask what-if questions about different interventions, given the situation. But its anticipation of the situation now is regrounded by observation. So it says, you know, you may have thought it could be something in this region, but it's actually down here. Okay, back, you know, now I'm grounded in the likelihood it's somewhere in here. The interesting thing is the models can take into account error in the data, too. This data is not from heaven. This data has uncertainties. It has error bars associated with it. The model can balance those things. So these techniques from computational statistics, particularly the particle filter, are extraordinarily powerful by taking into account uncertainty in model, uncertainty in data, and combining the two in a way that yields a fused estimate that retains the value of the model looking forward, particularly for counterfactuals, but keeps the model current and fresh with the latest evidence. So here with particle filtering, we're computing a distribution over possible states as we go forward. It's not just one estimate for a given realization. It's a distribution. And when the new data point comes in, that forms the prior distribution, and with the data point, it's combined to form posterior distribution. There's very flexible distributional assumptions in contrast to the classic Kalman filter, which are very narrow ones. And there's no presupposed nature of the underlying model, again, in contrast to the Kalman filter. It's quite easily defined, and it's much more general and powerful than the Kalman filter, which is very, very high performance, but unnecessarily so in a health context. So we've used this with a variety of conditions, particularly infectious diseases, TB, influenza, pertussis. This pertussis one is incipient, so I really shouldn't say that we've fully done that yet. But West Nile virus on the zoonotic front. One other thing I want to emphasize here, and I think this may be my last one, is this whole idea of using a model as a synthetic population. The idea here is that it can be very costly and challenging to run studies in the world to test out, for example, certain study designs or to test out certain statistical measures. It can be very expensive to do studies, for example, with administrative data to examine the effectiveness of using one algorithm versus another to classify occurrence of chronic diseases. And in this area, it can be very time-consuming, expensive. There's ethical processes we have to go through, and we've often turned to models as a first step by providing a synthetic population, as it were. We run a model knowing with full certainty what the underlying ground truth is in the model. The models, I'm not saying here the model is fully represented the world, but what's going on in the model, we know completely what it is. And we can apply a sort of statistical measure, say, of the sort we'd use for an administrative data algorithm, to data emerging from the model as if it were data that we had in the real world from an administrative data set. And we could assess the degree to which the classifications from that administrative data algorithm would match the underlying ground truth, the synthetic ground truth within this simulation model. So the idea is that we use the simulation model not with presupposition that it exactly mirrors the world, but we use it to kind of test out vulnerabilities of statistical measures, of study designs, in a way that allows us to learn more quickly and less expensively. So we establish sort of a synthetic population model as a virtual study. We perform simulation over time, simulating the study design or the statistical measure throughout the model operation. And the actual underlying situation in the model is blinded from the researcher. The researcher analyzes the data from the model, perhaps with some noise added to it to reflect the fact that real-world processes have noise. And then we examine so we go through the analysis procedures we would use for real-world data, and we compare the findings that we get from these analysis procedures with the ground truth in the underlying model, the ground truth in the simulation model from the agents in that model. So we've done this in a wide variety of studies. I don't have time to talk about them, but we can use it to judge the effectiveness of certain analytic procedures in understanding what's going on, or to understand the vulnerabilities of those procedures to certain types of situations. One of the areas this has come up with us is measurement of diabetes from administrative data. There are several algorithms that circulate in Canada for measuring the number of people with diabetes in administrative data based on things such as care-seeking behavior, pharmaceutical use, encounters with the medical system, diagnoses, test results, or what have you. We can evaluate using a simulation model. There's that possibility of evaluating these different administrative algorithms against the synthetic ground truth from the simulation model. Just wanted to comment on the importance of relationships. This is something which Jeff has long emphasized for me, and it finally got through my cranium. So the reflection here, and this is really worth emphasizing. This took a long time to get through my cranium, and I hope to spare you half that time to get through yours. So the observation here is that with agent-based models, we have an admirable flexibility to examine factors of importance within the population health disparities, and life course context. They're remarkable tools for reasons we've talked about. However, there is this danger, there is this risk that they are used in an atomistic sort of way. Atomistic is too strong a word. They're used in a way that focuses the attention on the individuals with the condition as the focal point and excludes except in as much as they interact with those individuals, others. And this perspective, while it can lend some insight, the fact is that it's often not that individual as a solitude, or even their interactions with their networks that often shapes the dynamics alone. It's often the dynamics of relationships between that person and others. Where Jeff first emphasized this for me was in the dementia context, where the natural tendency is to focus on the progression of the person with dementia. But half the issue there is probably not just the person with dementia, but their caregiving networks, the people around them, the people with whom they interact, the people who take care for them, perhaps unrecognized in the official data on the healthcare system. It's that triad often, as Jeff has oft emphasized, between the informal, the formal caregiver, and that individual who has the condition. That's often the essential unit of analysis. In agent-based modeling, we often think of the unit of analysis as being the person. But what I'm saying is we need to wake up as modelers to the fact that often the unit of analysis that's most fruitful goes beyond that person. Think as another case about maternal-child health. I'm privileged to work with collaborators in the area of maternal-child-infant health, or maternal-infant mental health. And in that area, it's not merely an issue of the infant's evolution and isolation. You have to consider their interaction with the caregiver to understand their trajectory. And to understand the caregiver's trajectory, it's very, very valuable to understand their interaction with the child. To understand the dynamics of postpartum depression, you need to understand its effect on the child and the reciprocal effect on the mom. So it's these relationships, not merely the dynamics of that person in isolation, that infant, that mother, that person with dementia, that's often central. And it's central because of care-seeking behavior, health behavior, the fact that caregiver, informal caregiver, helps you with self-management, helps remind you to take your medication, helps deal with the complications. And if we ignore this, we do so at our profound peril. We may miss some of the most critical intervention opportunities because we aren't considering the need for caregiver respite, or we're not considering the need to invest in knowledge of the caregiver or to elicit knowledge from the caregiver about the burdens for this particular patient. We're missing the opportunity, in short, to make a difference in terms of some of the key environments that are shaping that person's evolution and that could forestall their institutionalization. So this interaction with others, this dynamic of relationship, is arguably the centerpiece for certain types of health problems, and I would argue is also of great importance for many types. So, here we need to be cautious in saying agent-based modeling. We can't make it exclusively just about the agent as the unit of analysis. We need to think often about dynamics of relationships as the type of analysis. So I've listed some cases here where this plays a role and where we've, for many of them, we've been quite involved. And, I'm very privileged with Jeff to be looking at this at a preliminary level now. Hopefully, as time goes on, it will become quite central to this issue in the context of patient flow. This is one of the priorities we have. We were just talking yesterday about getting into the model there. This feelings and pregnancy study looking at postpartum depression with gestational diabetes, dementia, and that Jeff has been doing the BPSD, biopsychosocial correlates of dementia. Okay, so some high-level points, and then it's Dylan's turn to shine. Oh, really? Okay. Okay, some high-level points. Addressing health disparities requires a combination of approaches. It's not just about agent-based modeling. It's not just about big data. There's many powerful existing and emerging tools for enhancing modeling of complex health interventions and of health disparities. And a pluralist approach in this area can be especially effective. And, the models we build, the fact is they're likely to be fallible for a long time. And really what we need to invest in is learning more quickly from them. It's not about honoring them as the centerpiece of our knowledge. It's about using them as part of a learning loop and making that learning go more quickly, more deeply, and more robustly over time. And that involves some techniques to incorporate new evidence, but it also involves the social context of modeling such that it's embedded and that we're soliciting feedback on and ideas about our model. Okay, so those are all the comments I have for today. I hope that's been somewhat useful, and I'm certainly glad to talk about this after Dylan's chance to shine. But I guess there's food out there? Is that right?
There would have been about 45 minutes.
Okay. Fair enough. So, do you want to check?
I know.
It's out there.